So, what I am going to do is next 30 minutes is how we should do a complete echo protocol for echocardiography. We always start with the left parasternal window and I will divide this talk into two parts. Go from top to bottom as Prashar sir has said, right from top to bottom, left to right, and what you see in this imaging quality is first this is a chest wall, RV free wall, RA, anterior aortic root, posterior aortic root, right coronary cusp, non-coronary cusp, anterior aortic root is in communication with interventricular septum, posterior aortic root is in continuation with AML, then LA free wall has got a PML connection and free posterior wall. Number of things which you can see over here. Let us start with RA. You can see any RV dilatations. Second, you can look at an aortic root. Third, you can see the two cusps whether thickened or normal. You can see any hole through interventricular septum. Same, you can look at an LA size, you can look at an LV size, and then you look for any prolapse of AML or PML. Correct? Once we have done this, we rotate a transducer 90 degree, and look, once I am rotating a transducer 90 degree, as I said, if my aorta is in the center of this imaging quality, my aorta will come in the center of this imaging quality. Now, all three leaflets of the corner aorta is aortic valve is seen. Here is the left coronary artery which arises, here the right coronary artery which arises, and there is no coronary artery arises from non-coronary cusp. Again we go from top to bottom, right to left. First we see the RVOT, then we see the pulmonic valves, and by angulation we can see a bifurcation of the pulmonic artery to right and left pulmonic artery. Here we see a tricuspid valve, RA, LA and interatrial septum. If I start angulating my transducer towards my left hip, look how good mitral valve I can see. Not only the mitral valve which I can see over here, I can see the all basal 6 segments of LV in contractions. And I said in the beginning only, if you have to look for wall motion abnormality and imaging quality is good, perpendicular contraction is much better than parallel contraction. So, we can look at all basal 6 segments of LV, and on top of that we can look at the mitral valve close AML and PML with one commission on this side, the other commission on this side. If we go a little again towards left hip, I am seeing both papillary muscles, one on this side, other on this side, and this what I have said in the beginning is, if you are looking for a mitral stenosis in a 4-year-old child or a 5-year-old child with mitral stenosis, if you have to look for both the papillary muscles, if one of them is absent, obviously this is parachute mitral valve. We can look at all 6 segments of LV again, 6 plus 6, 12, and then again apical 4 segments which we see, and all those 4 segments now you can say with confidence are being contributed by what? LED. So, this is how we look for 2 dimensions imaging for LV in short axis view. Coming back to the same thing over here, once we look at it, we look at a D-shaped septum in case RV pressure are more than LV pressures, and look over here, this septum is posted towards RV, suggesting that LV pressures are more than RV pressure. We come back to the plaques window, interrogate the RV RA inflow view. Here is the RA and here is the RV, and this window along with parasternal short axis view at aorta and tricuspid valve, these are the 2 windows which we exploit for evaluation of TR gradient. And similarly in this window what we exploit the evaluation of pulmonic valve, whether this is thickened, stenosed and increased flow velocity, and we assess how much is the pulmonic regurgitation is. And if we happen to look at this particular valve again, we can look at a jet width height oblique LVOT height, vena contracta, whether at its aortic valve or a pulmonic valves. This is how we scan for 2D. I have not touched a color till now. I will move on this imaging to apical window, and I will go and scan right into the apical window is. And I have been saying these words again and again, your apex should be contained into this triangle. And look at this angle of evaluation is almost 75-degree angle of evaluation is. Now you have to optimize your 4-chamber view. This descending aorta should always be seen in a 4-chamber view. You should be able to see these pulmonic veins on right and a left pulmonic vein drainage over here. Once we have optimized our image, what all structures do we see? We again go from top to bottom, left to right, and if you have to go from top to bottom, right to left to right, then what all do we say is, we see the first LV, LA, RV, RA. We look at the basal, we look at the septum, we look at the lateral wall. Here is a AML, here is a PML, and here is the LA, intra-atrial septum, and RA and RV on top. Most important thing which we require in this 4-chamber view is, we need to evaluate what exactly the wall thickening abnormality is, and all these wall thickening abnormalities are dependent on a good imaging quality. And if I have to divide this image into 3 parts, I will say this is basal septum, mid septum and apical septum. This is apical lateral, mid lateral and basal lateral segments. And to repeat again for the people, this is only one view where we see all the 3 coronary arteries, mid and basal septum supplied by RCA, mid and basal lateral wall supplied by circumflex, apical lateral and apical septum supplied by LAD. Then we rotate to 2-chamber view to make it anterior wall and inferior wall. Anterior wall does not have any papillary muscles. सांस लेके रोको हल्का सा, अंजे, सांस लो, रोक लो. And look how good the imaging quality has converted with the help of inspiration. I can see a very well whole of the anterior wall, I can see whole of the inferior wall. Mid and basal inferior is contributed by RCA and rest of the segments are contributed by LAD. We rotate counterclockwise positions, the papillary muscle disappear, this become anterior septum and this become inferior, posterior wall. So, if you have to look for a wall thickening abnormalities, in every way you have to spend some time looking at 4-chamber, 2-chamber and 3-chamber views. Without that, it is not possible to comment on wall thickening abnormalities. Use aid of respiratory movements, whether these images are seen good with or without inspirations. Are we clear about this? Then once we have done this 4-chamber LV function evaluation, we always look any structure which is seen extra in LA or RA or in RV. And once we have done this kind of an evaluation, we shift to, अब सीधा लेट जाइए, subcostal window, and all of us in subcostal window, 2 things are very important. First important thing is, look how is the RV and RA they are behaving for this patient. And look, this is a very good view for looking an RV free wall contraction. And if I rotate my transducer counterclockwise, I am opening up my IVC, and all of us know by this time this IVC is helpful for evaluation of volume condition in a patient. Subsequently, we go to suprasternal window in the same lying down positions, and we have taught many positions of a suprasternal window. One of them is looking at this suprasternal window over here, where we look for descending aorta, presence of a great cranial vessel. This is first subclavian artery, then left common carotid and then the innominate artery which arises from these vessels. And as I said number of times, like we need to look at 5 tricuspid windows for assessment of a TR gradient. We need to look at 6 aortic windows to look for a precise aortic valve gradient. We go back now, turn ले लीजिए, उल्टे हाथ में घूम जाओ. This is what the 2D scanning is. And once we have done these 2D scanning, the other couple of things which make a lot of difference in 2D scanning is the measurements. How do we measure the 2D scanning measurement is? This is what we have evolved over a period of time is little modified what the American Society of Echocardiography says. We may be overestimating or underestimating by 1 millimeters of a difference. I do not say no, but in this way all of us will measure the same thing what we have been teaching over a period of time. Drawing a line right into the center, then moving to the tip of the mitral valve leaflets, and finally going just distal to the tip of the mitral valve leaflet. Many of these things they have been recently modified and adopted by American Society of Echo for calculation of various chamber dimensions. And once we have seen this kind of a things, let us see how do we calculate LV dimensions. And I will say at this point, look what exactly these dimensions ask for. If you happen to look, the first top dimension on left hand side, I saw many people measuring direct interventricular septum. Look, the first top dimension which is asked in this view is right ventricular dimension during diastole. And if we ask this right ventricular dimension during diastole, we are not going to start from here. We have to start from a right ventricular dimension during right ventricular dimensions during diastole, and this is what we are going to start with the right ventricular dimension during diastole. Next dimension is asked is interventricular septum during diastole. Third dimension is asked as a posterior wall during dimensions during diastole, and this is how we complete the diastolic dimensions for this particular subject. Then we move to systole, measure the same dimensions during systole. And what does it gives you at this particular moment? It gives you many things like ejection fraction, fractional shortening. Then the third one is what is the LV mass in this particular issues are. Now I can say and I can vouch is, look, this is the time we not going to consider EF over here, but we can consider fractional shortening, but LV mass is still being utilized in a day-to-day practice. At a level of level 2 or level 3, now we are able to say which patient has got a concentric LVH, which patient has got an eccentric LVH. And this is what is done today basis on this LV mass by M mode. Once we have done this, we move on to the next measurement, and which measurement is the next one is D excursion, EF slope, and we move our cursor to mitral valve. What we get is first is a D excursion. Every machine will have its own nomenclature. D excursion is 24, and then we go to EF slope, and here the machine is giving you 135 millimeters per second. And the last measurement once we have done this is we go and measure the E point septal separation. As Parashar sir has said, like anything less than 7 is considered as normal, and more than 7 sir has showed you one of the slide. And believe my word, even I started utilizing over a period of time in my day-to-day practice, utilizing E point septal separation and correlating with my own ejection fraction which I calculated later on. They come very close by. So it will be an additional tool for you to look for ejection fraction by how much the ejection fraction is. Though we are not talking of percentage wise, we will say mildly reduced, moderately reduced or severely reduced ejection fraction. Once we have done this measurement, obviously the most important measurement, another one is aorta, LA and AV cusp separation. And now look, you have a chance where to measure what. If I have to measure this imaging quality over here, look, I am able to see a very good aortic valve opening out here. This is not seen over here and not seen over here. And one point is aortic valve opens always in rectangular box. So I can measure this particular segment or this particular segment wherever I feel the best segment is, and I am going to do that. I am going to measure my aorta, I am going to measure my LA. Now I am looking for a LA where I can see the best LA is, and then I am going to measure my aortic valve opening. And once you keep on doing these things again and again, things will automatically fall in line for your regular practice. And my humble suggestion again and again is please do a complete echo. Don't do a scanning echo. Scanning echo is majority of time as fallacious. It's not that you are not able to get information, but you will get information which is incomplete and which you can only realize once you have done suppose a mitral stenosis and you have not looked for a tricuspid valve. You have done a mitral stenosis intervention, but you left a tricuspid valve because you forgot to scan that particular part. Third point, in the same long axis view, the most important thing is to look at what? Mitral valve area. And this we have been emphasizing over a period of time is we go to papillary muscle and come back towards mitral valve, and wherever we see the complete mitral valve, this is what we are at the tip of the mitral valve leaflets. And at this point we go and measure the mitral valve area. And we measure the clear tricuspid valve area, mitral valve area, and this mitral valve area I am just planimeterize it, it should be inside. And whatever you say, whatever the diagnosis is, I am repeating again and again, mitral valve area is the final area, whatever the gradient, whatever the other things are, except for one condition where the mitral stenosis is distal to the mitral valve area, as in subvalvular apparatus. In subvalvular apparatus, mitral valve area will come out to be normal, but stenotic gradient would be just distal to the valve leaflet and seen like a tunnel in parasternal long axis view. Once we have done this mitral valve area by 2 dimensions, and what we need to measure is by a magic number, which everybody asks, hey, how much is my ejection fraction is? And just exams, we get a result in exam, everybody asks you, hey, how much is the number is? And here everybody, as soon as they refer for echo, the first thing they will ask you, what is the ejection fraction of this patient? And on the same thing, we need to look at the proper imaging quality, spend time, and this is what I have done is, I am trying to trace the endocardial delineation, or other word is what is black and white interface. Black is LV cavity, white is the endocardial margins. Once we have taken an area, you have to take a length that gives you on a volume. Look, his end diastolic volume is 73 ml per 73 ml of a total volume. Now I am scrolling to systolic motions and systole, maximum volume, going to press a measure button and then measure, start from a medial annulus and go to the apex and back to the lateral annulus, and do the same thing, and ejection fractions comes out to be 47, despite in the best people, the person who have been doing echocardiography for many years, even I can calculate a wrong ejection fractions. So why the wrong ejection fraction is, I am not spending time adequately for tracing the endocardial borders. At your level, take my words, take our words, take Prashar sir's advice or fatherly advice is, always calculate ejection fraction, don't depend on eyeballing. Hey, it's normal, it's not that. Once you will keep on spending and think how much is the ejection fraction is, and then trace the ejection fraction, that will help you in coming to a conclusion over a period of some time when you become expert for a eyeballing ejection fractions. At the same time, two important things we should add at this moment, by only M mode, by only 2 dimensions echo. One is MAPSE, one Prashar sir must have told you in between intermittently, mitral annular plane systolic excursion. As I said on a first day, like heart apex is fixed, but it is the base which moves towards an apex. This is how you can measure, it is almost 13 or 14 millimeters, but this is not the right way, you have to go a state up, and this can only be possible when there is a presence of a line along with this measurement. Many machines will have a dotted line which transfers along with this, and this is what 11 or 12 millimeter of a MAPSE, which transforms into systolic function, and similarly we look at TAPSE by putting a sample volume into RV, which transforms into systolic function of RV. And why the systolic function of RV is more important, the basic answer I can give you again and again is, think of a pulmonic embolism. What makes a difference in the outcome of a pulmonary embolism? What makes a difference in the treatment modality of a pulmonary embolism? If a patient, you show a thrombus, and if you have a poor RV systolic function, this is a time you have to react very fast versus a person who has got a normal RV systolic function. So, calculating an RV systolic function will become damn important सीधा ले जाओ during all these procedures. Next comes, we should not forget about it. This is a time where we should learn to measure our IVC. It's not that my IVC is this much. Once you start measuring and realizing how bad and how horrible your assessment was when you did not measure your IVC. You have to measure IVC like this M mode distal to the hepatic vein drainage, and this is how we always look at measuring the IVC. And now look at this, with inspiration his IVC is collapsing, and with expiration his IVC size is becoming normal. And here is one like where you can measure an IVC from this point to this point, and with collapse it is from this point to this point. His IVC is normal, less than 20, and I gave you that rectangular box. More than 50% collapse, normal IVC, RA pressure are 5, this means he is euvolemic. And once you go back to your country, place respectively, those places are really humid, especially in summer. You will find majority of your patients are dehydrated. Look at their IVC, their IVC would be only 10. And especially those people will be more dehydrated whom we are asking for a stress echo because they have been fasting for 2 to 3 hours. Those people will be really dehydrated, like in one of the religion, we have to keep fast a whole of the day, not to even drink of water. And in extreme summer, we are sweating a lot. What happens to a hydration? Try this IVC, and this is worth publication of a paper back in your country. Once we have done this, we go back, करवट ले लो, and now the time comes for a Doppler. Where all you should look for a Doppler now? First thing where you should look for a Doppler is switching on a color at aortic valve levels. This Doppler box should be as small as possible. Look, this was a Doppler box when I opened up a machine. This was a Doppler box. Look at my frame rate, 14. Look at the colors, they are bad. And once I have reduced my Doppler box to smaller size, my colors optimization has become better, and now frame rate has gone 32. First place where you will switch on your colors is at aortic valve. What is it? It gives you information. What is there before aortic valve? What is there after aortic valve? After aortic valve, if you happen to find a turbulence, it will tell you, look, there is evidence of any aortic stenosis or not, and before the aortic valve, you will find whether there is any aortic regurg or not. Once you have said this, look at this mitral valve. You are able to see again whether there is regurgitation or not, or whether there is a forward flow, stenotic or not. But the most important thing is, what we observed over a period of time is, look at this small trivial MR which is seen over here. Can you realize? And what we have observed over a period of time, if we are able to see a trivial MR in this situation, it means this MR is definitely trivial or mild, because we are not perpendicular, we are parallel, we are not parallel, we are perpendicular over here. And if I am seeing something which is perpendicular, it means this is much more than this when it becomes parallel. Same view you will be able to see your flow across the mitral valve. If a stenotic lesion, you will be able to see a stenotic lesion. Once we have done this, we rotate our transducer to 90 degree, and the first and foremost thing, we look at the pulmonic valve, and by switching on the colors, we jolly well know whether this patient has got a pulmonic stenosis or not, and if it is there or not there, we put our sample volume distal to the tip of the pulmonic valve leaflets, switch on a pulse wave. Now, my pulse wave is able to utilize all this velocity, go to the measure and let's see how much is the pulse wave velocity. It is 0.7. Do I need to convert to a continuous wave Doppler? No. We do not recommend that we should convert to a continuous wave Doppler. By this, you will be able to get rid of that one abnormality which I showed you by case demonstrations. And once you have looked at this pulmonic velocity, if its turbulence is present, if its alias is over here, obviously you switch over to a continuous wave Doppler to contain the Doppler spectrum pattern and measure it. Similarly, at the same time, I will spend time over here to look at pulmonic regurgitation also. And what over a period of time we have realized, if we are able to see a pulmonic regurgitation jet, whether it is mild, moderate or severe, is we can calculate mean pulmonary artery pressure to a very large extent. Now, from this window, I will switch over to the window towards tricuspid valve. Now, at this tricuspid valve, I should always try to look for a TR gradient, and especially if the patient is of lung condition or a chronic obstructive pulmonary disease. Look, we are able to see some amount of a TR jet in this particular subject over here. One window where we are looking for a tricuspid regurgitation jet. From there, I will go to a RVR inflow view, again assess tricuspid valve, again assess TR jet gradient, the second window where we are going to assess a TR jet gradient for this particular follow-ups. And somebody who was asking a coronary sinus on that day first, where I was not possibly, my mind was not responding to the call of coronary sinus. Here is a coronary sinus somebody was asking on that day. Once I am done this with the plaques window, I have done with the short axis window, I have done with RVR inflow view, and one more thing we can look at this particular window is looking for an assessment of any intra-atrial septum, which can be seen in this particular positions. This intra-atrial septum difference or a color flow would be very small, because my LA pressures are 10 and my RA pressure are 5. The gradient is only 5. And if you happen to translate into velocity, it will be a 1 meter per second would be the flow velocity across this LA and RA. Going back to 4-chamber view. This is one view which will give you ton of information for a Doppler point of view. And what is this tons of information from a Doppler point of view is, first and foremost, we look at mitral flow pattern, and again the same thing I will say, if you are looking for a mitral flow pattern, always distal to the tip of the mitral valve level, and what the valve level you get is mitral E wave and mitral A wave. And if this velocity is aliasing, and what you do is, you trace up this velocity spectrum to get a peak and mean gradients. And this is very important to get a peak and mean gradients in any patient whom we suspect a mitral stenosis. And this is one method all of us have learned over a period of time, how to look for a flow velocity integral or a VTI or a TVI, then look for a peak velocity, mean gradients. Once we have done this, we go back to look for any regurgitations. Then we look at a Doppler spectrum pattern at the aortic valve, and here we have to keep a sample volume just distal to the tip of the aortic valve leaflet, and this is how the sample volume of aortic valve leaflet is, which is kept just distal to the tip of leaflet to have an aortic flow velocity. And if I move this sample volume, look at the sample volume, if I am moving before the aortic valve, what I am going to interrogate is LVOT velocity. This is LVOT velocity and this is aortic valve velocity for the same subject. And this helps looking at aortic valve velocity, VTI and peak and mean gradients versus LVOT velocity, VTI and peak and VTI, we are able to calculate aortic valve area if we incorporate the LVOT diameters. Once we have done this, we come to 4-chamber view. We start looking at tricuspid valve. We can't see much of a tricuspid valve over here. We look at the flow velocity across the tricuspid valve, again looking at peak and mean gradients and velocity if the velocity is high. And here is third window where we start looking for a TR jet, and as you see over here, we can't see any TR jet, and we move a space up which has been taught to us by Colonel Prashar sir for many years, and I often write in my reports as Colonel Prashar's window, and where this we are able to see a very good tricuspid valve, and we have to evaluate this TR jet in this particular window one space up, and believe my words, like still going in our lab is, we started looking at the tricuspid rigor in this particular window, and almost 80% of the patient we are able to give a correct answer that majority of time the peak gradient by TR jet in this particular window is the maximum. And recently the American Society of Echo has also adopted this window for focused RV-RA view. We are not bothered for echogenic interventricular septum at this time. I am now bothered for my bothered for my TR gradient. Look, if I will spend time, you will start seeing a TR jet over here. Can you see a TR jet? And once you have to measure, you get this Doppler sample volume into the neck of this TR jet. Look, and once I am into the neck of the TR jet, look what things I am getting over here. There is no way that you can calculate a TR gradients. When I was working in Jefferson University in 1991, my boss always tell you, like, if you can't find a TR gradient means you are hungry. You want to leave the lab and go out. It's seen in every person. It has to be a normal TR gradient. Look how much is a TR gradient, 16 millimeters of mercury. Every patient has it. Every subject has it. If you add 5 to it, it will be 20. And 20.6 of a 20 is 12, and 12, 2.1, 14. 14 is a normal PA pressure. How can it possible that we do not have a PA pressure to push up blood? We have to have a pulmonary artery pressure to push up blood to the lungs. So, it is impossible that you do not see a TR gradient. It's practically every person. Only thing is you have to spend time to look for a TR gradients. So, this is fourth window where we see a TR gradient. And once we have seen this TR gradient, two more things which we need to look at this particular subject is, we need to look at RV-RA dimensions, which I told you a couple of days back, one day back, and then look for a TVI of RV free wall contraction. Here is the RV free wall TVI, which is more than 9.5 considered as normal. Once I have done all this measurements, the most important measurement of what? Anything left? Diastolic dysfunction, man. The most important thing is, we look at a septal TDI. Here is the septum. Here is a lateral wall. And by taking an average of those two and utilizing the E wave, we get what is the E to E prime average ratio is. Correct? And then we take an LA volumes in that particular segment, and I have showed you how to take an LA volume for this particular segments to assess for a kind of a diastolic dysfunction. And this is what all we can do in 4-chamber view, and then we come down to see the late jaw, jelly. Subcostal window, and in subcostal window the most important thing I have shown you by 2D what to look for in RA pressures, but at the same time this is 5th window where we will try to involve and localize the TR gradients. And I have showed you in one of the cases, like I could see the maximum TR gradient when in subcostal window is when this jet is aligned to interatrial septum, and provided this aorta should be closed during this time. So all these 5 window, if you are looking for a COPD patients, otherwise also if you have a LV systolic dysfunction, you want to look for a PA pressures, you have to utilize all these 5 windows again. Once we have gone from this, we have to go to ascending aorta and a descending aorta, and what I always suggest is take a bed sheet or a pillow, put it behind the neck of a subject rather than behind his head. When you put it behind the neck, you can extend his neck so that, and little on the left hand side, you can look at it in that particular fashion by looking at ascending aorta and descending aorta for their functions. This descending aorta is very important to rule out any coarctation of aorta and to look for any severe aortic regurg. Third important point is always take these people on a right anterior oblique view so that we can look at what exactly the ascending aorta gradients are. Look, the same subject, I am able to see a good ascending aorta as compared to previous view, and this view would become more relevant in cases of aortic stenosis. And once we have done this ascending aorta, descending aorta, arch of aorta, here we can look at descending dissection of aorta as well as other features. For aortic valve, which all windows we should utilize? We should use 5-chamber, we should use 3-chamber, we should use right parasternal window, then we use arch of aorta, then right anterior view and a subcostal window which we can utilize for assessment of aortic valve gradient. And you need not take the average, you have to take the maximum gradient during this time. Jelly. Look, here I can see an aorta, one of the batch was demonstrating a very good aortic flow with a gradient of almost 6 meters per second. I can switch in and look at this. Can you see this aorta? And if sometime the jet is so eccentric that you get a maximum gradient in this particular window of subcostal window. And this is how we try to complete a complete aortic, a complete echocardiographic study. And if you look at a watch, it took me almost 30 minutes, 32 minutes to complete my complete echocardiographic studies. And once we have done this, fortunately these machines have got a very good setup where they have, you can store your all AVI clips. You go back, reanalyze and then make a diagnosis, and if any discrepancy is there, you can consult any one of your colleague over there, or you can download, send it by email to us, we will reply for that kind of things. But provided adequate imaging is present so that we are able to make some diagnosis and some other findings. At this point, I stop at this, my talk over here, and then I will take up any questions which you have still in your mind left behind.